Thank you for joining us today for our presentation on when picky eating goes awry, the difference between selective eating and ARFID. Just a note that today's webinar is being recorded. I'm Kara Bohan. I'm a clinical psychologist and Senior Vice President of Clinical Programs at Equip. And just before we get into the presentation today, I want to acknowledge Equip Academy, which is the program that will be offering free CE and CME credits to eligible clinicians today for this live webinar. Created by Equip, which is a virtual evidence-based treatment program serving patients of all ages, diagnosis, and backgrounds across the US, Equip Academy was developed with a clear mission to educate the clinical community on eating disorders for free. This year alone, it's estimated that 5.5 million Americans will get an eating disorder, and only 23% of them will get treatment. And an even smaller fraction of that will get treatment that works. By uncovering research, insights from treating different populations, education on lesser known signs and symptoms, and recommendations on guiding patients to treatment, our goal is to provide you and your colleagues with tools and knowledge to ultimately help your patients get access to treatment that works. Now, it's my pleasure to introduce today's presenter, Dr. Jessie Menzel. Dr. Jessie Menzel is the Vice President of Program Development for Equip Health. She's a licensed clinical psychologist and a former associate clinical professor in the Department of Psychiatry at the University of California, San Diego, where she founded the Pediatric Eating Disorder Program at the UCSD Eating Disorder Center for Treatment and Research. Dr. Menzel has over 15 years of clinical and research experience in the field of eating disorders and has worked with individuals of all ages and across all levels of care. And just a few quick housekeeping tips about the webinar. Attendance for the full 90 minutes is required to be eligible for CE or CME credits. Presenters may take brief pauses throughout the presentation to address questions, but there will be more allotted time for Q&A at the end. So please utilize the Zoom Q&A function at the bottom of your screen to ask questions. Lastly, slides will be available upon request. If you're interested in receiving a copy, please email ce@equip.health following the presentation. And thanks again for joining, and hope you enjoy today's event.
Thank you so much, Kara, for that intro. Welcome again, everyone. Very excited to speak to you all today on this topic. A few housekeeping items before we get started. Just want to disclose that I have no conflicts of interest with today's presentation. Equip receives no commercial funding for this event, and I also do not have any financial relationships with ineligible companies to disclose. I am the person you can email if you have any complaints or concerns related to today's events. Please feel free to send those to me. And make sure you pay close attention to the continuing education requirements. Note that you do need to stay for the entire duration of the presentation in order to be eligible to receive CE credits. All right, so let's dive into today's topic. And I thought that we would start today with a couple of case examples to get us going, because the big thing that I want to focus on today is how do we tell what I'm going to say is quote unquote more normal or normative, picky or selective eating, and then what is ARFID and how do we differentiate between the two? So I thought we would start with an exercise. I hope you all are ready for a little bit of crowd participation this morning. Testing, not really testing, because that's definitely not a test, but seeing sort of where you all are coming at this from today. So let's start with an example of a 3-year-old girl, we'll call her Lana, who's from a mixed race, middle-class family. And she used to eat everything up until about age 2, but since then has dropped most of the veggies from her diet and doesn't like trying new things. Her family finds that she's frequently cycling through new food, so it seems like each week she wants something different. What was in last week is no longer in this week. She refuses to eat food that is broken or that has previously been opened. So for those of you with toddlers, the notorious broken granola bar, she refuses to eat. The family may often prepare separate meals for her. So family's usually eating one thing and Lana's eating something else. And parents are frustrated by the unpredictability of what she will eat. So we can use the chat, and I'm curious, just kind of putting your thoughts in here. Does this sound like picky eating, selective eating, or perhaps something that's more of a problem? Curious to get people's impressions. Okay, so we've got a vote for picky or selective, lots of picky eating. Okay, awesome. Great. Okay. Yeah, I see somebody mention development, so going probably through some developmental changes. Lots of vote for pickiness. Ooh, picky but need to understand her process. Sounds like food jagging potentially. Oh my goodness, wonderful. Okay, lots of vote for pickiness. So curious, and we can get just like a few bits and pieces here. What makes someone land on picky? Why does this sound picky to some of you? Definitely acknowledging that, we have more to learn. I see some great points here. Curious about growth, right? Curious to know just more about her. So maybe if there's some other things going on. So some of you are saying this just kind of sounded normal. Sounds like kind of meal cycling, pretty typical to have separate meals for young kids, developmentally really common, toddlers exploring their boundaries, absolutely. Right? Learning how to exercise independence. They're aware of themselves and their role in the world, and they're wanting to express themselves in that way. Wonderful. Yeah, wanting to say no. Okay. Well, I'm not going to give you any answers just yet, but you're picking up. Yeah, sounds just like my kids. And definitely so Lana is a made up person. Parts of her are drawn from real patients. Parts are drawn from my own experience of feeding my children. I definitely had a kid who was like the broken granola bar kid. If you had already opened something, they didn't want to eat it. And like that unpredictability piece, right? You never know exactly what's going to be in with toddlers. Yeah, they're changing and they're experimenting with their own desires. These are all really wonderful points here. And you're hitting on exactly some of those things that we kind of consider or need to take into consideration before we jump to a conclusion about whether or not something is a problem. So I think age is a really big factor here. At 3 years old, there's lots going on developmentally, and it's really normal, particularly as toddlers begin to explore their worlds. Oh, and Celia, we will get to what is the difference between picky and selective here in just a minute. For them to start kind of, again, setting those boundaries, right? So really common for kids to no longer want to eat what they used to eat as they enter into toddlerhood. All right, let's move to another example. So this example is now Chris. Chris is a 15-year-old non-binary Asian teen from a middle-class family. They eat primarily pizza, plain pasta, chicken nuggets, and French fries. Their preferred foods have become narrower over time. They do not appear food motivated. So parents note that they often have to remind Chris to eat or push Chris to eat. They will avoid meals over at friends' houses, usually only going out to eat with friends if they're going to get pizza. And they feel embarrassed about their eating habits, but don't have a problem with what they eat. So thoughts here, picky, selective, or a problem? Problem, the lack of motivation to eat. Okay, I'm seeing ARFID, I'm seeing problem. Awesome. Okay, so for those of you who are participating in the chat, let's try to put some of that rationale in there. What is it about this case that's making you point towards problem or selective? Definitely acknowledging that you all need more info on these cases. Okay, decreased desire to eat, the narrowing over time, the embarrassment. Yeah. A lot of you are picking up on that social piece, not only just that they're feeling embarrassed, but that it is impacting how they are interacting socially and how they are choosing to socialize. Some of you are noting the potential for neurodivergence here. Okay. Really wonderful points. I'm just scrolling through some of these because they came in fast and furious. Yeah, the part about like the low motivation and drive to eat, parents needing to push them, the disinterest in food. Some of you noting the kind of the really low number of foods. Granted, we don't have the full nutritional picture here, but some of you are noting that. Okay, lots of comments on the social part of this, the social nature. Excellent, excellent. So again, a lot of you are picking up on another clear kind of distinguishing feature of this case, which is this beginning to impede on functioning, right? We're going to talk a lot today about that impairment in functioning piece, both socially, because social is an absolute consideration here when we think about whether something is a problem versus not. So functioning socially, but also but also potentially, not potentially, but also health-wise. So physically, when is something starting to cause problems? So those are going to be two key things that we talk about today when it comes to saying whether or not something, again, is picky or selective or just a problem. Um, so somebody mentions here the need to consider this through the youth's lens. Yep. Right. Well, maybe it's not bothering them a lot right now. It clearly are aspects that are starting to bother them, and those things could potentially be magnified as they continue to develop and get older. Yeah. Mhm. All right. So let's start to talk a bit about definitions here. And we're going to revisit both of these cases in just a minute. So picky and selective eating are often used very interchangeably and for good reason. They are defined in pretty similar ways. Now, I would say there's probably not one clear consensus definition about pickiness. When you dive into the literature on pickiness, there are a lot of different ways that it's defined. And I really like to narrow in on these three features that I think are usually a part of most definitions of picky eating. So picky eating involves struggling with new foods. So this might be, not trying them at all. So that element of like kind of neophobia. Or it could just be, really having a hard time when they try new foods. They're very reluctant. They tend not to enjoy new foods. Definitely variety, and eating a narrow variety is part of almost every definition of pickiness. And then finally, difficulty to please, particularly at meal times. This might also be described as being fussy. So this is more of an emotional component. So it's, again, not just that this is a person who accepts few foods, but it's hard to get it right. So this could be like being just very particular about the types of foods or the way they're prepared. But this could also be more, again, emotional distress at meal times that's present. Now, pickiness and selectivity are both of these things are definitions of picky and selective eating. In the literature, what tends to distinguish both of these is that pickiness is perceived as being transient or defined as being transient, whereas selective eating is more persistent and stable. And note, I'm not calling selective eating ARFID because selectivity could merely mean that you have a highly preferential eating style and a desire for sameness in the foods that you eat. But instead of this fading away as you get older, it persists, which is certainly true for a number of people. So selective eating is more of a stable style of eating, more trait-like, whereas picky eating is something that is present for a period in your life, typically early childhood, and that does tend to get better or ameliorate with time. So let's look at how this is kind of showing up in people's lives. How often are we seeing picky eating? Is it true that picky eating gets better with time? Um, Prevalence-wise, we do see that the highest prevalence of picky eating or reported picky or selective eating is in the ages of 2 to 5 years old, so toddler years. Early childhood. Up to 50% of kids are identified by their parents as being picky eaters. So, up until again about the age 5. And there's agreement in general that pickiness peaks right around this time and then tends to decline as we get older. We have data that support this from more kind of late childhood, where we see that the prevalence of picky eating drops to about like 7 to 27%, so more around like a quarter of late elementary school kids are identified again by their parents as being picky eaters. We have almost no data from adolescents. I have a really hard time finding picky eating prevalence estimates for people who are teens. But in adulthood, we have a small but growing body of literature that validates that picky eating is still present in some individuals into adulthood. So, up to almost a third of adults self identify as being picky eaters. Now, to what extent they're picky or how narrow their range of preferences, we don't know a lot about that, but these are individuals who say, yep, I am a picky eater. So the data do somewhat support that, picky eating is less common as we age, which seems to suggest that it fades over time. We'd probably say that these adults are more selective eaters because their pickiness has persisted over time. But in general, data support that the most common period in life in which to encounter pickiness is in the toddler to early childhood years. Now, a lot of this data about sort of pickiness fading with time, or when it's present, or how it changes, and whether or not it's a phase, comes from correlational or cross-sectional studies. So we're really just looking at like moments in time and people recalling eating styles from early childhood. There was one study, though, that did look at the kind of trajectory of picky eating and how it changed longitudinally. This is probably some of the best data I've seen. Now, this study was published in 2020, and it was came out of Michigan and was conducted exclusively with low-income families. So it included 317 mother and child dyads that were almost exclusively recruited from Head Start programs. So just keep in mind that this is a very specific demographic that was looked at in this study. And what they did is they evaluated these children at 3 to 4 years old and for pickiness, and they looked at a number of other factors too. They looked at some elements of emotional functioning. They also looked at some parent or caregiver traits and behaviors. And they classified the kids in this study into low, medium, and high picky eaters. And they used a subscale from a questionnaire called the Child Eating Behaviors Questionnaire. And they used the food fussiness subscale, which is 5 items. And the items are assessing for whether or not your kid readily tries new foods, if they enjoy trying new foods, if they eat a narrow variety of foods. And I think whether or not meal times are difficult, or they're difficult to please at meals. So that's kind of how they were defining picky eating. And so they took kids who scored in the highest third or quartile of these on this scale, and the kids middle and low. And what they found when they classified these kids at age 3 and followed them over the course of several years up until they were 11 years old is that the picky eating traits that the picky eating styles that they exhibited at 3 years old largely stayed stable over time. So kids who were low on pickiness tended to stay low on pickiness. Kids who were moderate on pickiness also tended to stay moderate on pickiness. Kids who were high, though, on pickiness not only stayed high, but they continued to increase in their pickiness over time. So one of the things that this study seems to suggest is that perhaps pickiness, the pickiness that we think of as being more transient pickiness, or the pickiness that goes away, may never have been that picky to begin with. So those of you who plugged into this being kind of a normal developmental phase, it's possible that, parents are accurately recognizing when their kids are young that this is just normal, this is typical. And therefore, again, like, these are not kids who persist in their pickiness because they were never picky to begin with. Their eating has always kind of been typical. However, these kids in this high group, moderate and high group, seem to defy the logic that, again, pickiness gets better with time, that if we leave it alone, it'll go away on its own. Because what this does suggest is that pickiness, if kind of left to its own devices, either stay stable, and maybe that's fine if it's just a moderate level of pickiness, but particularly when it is bad, when it's high, that it only worsens. So this is really important and interesting data, because I think one of the most common things that I often encounter when I talk with parents and when I talk with caregivers is this these parents or caregivers who are really worried about their child and are frequently met with kind of the advice to just wait it out. See what happens. It's not a big deal. This is normal. It's a phase. It'll pass. And this seems to suggest that there is a subgroup for which we do need to be a little bit more concerned about the pickiness and intervene a bit earlier. Celia, just really quickly, I'll answer your question from the Q&A. The items on the subscale again ask about, is your child afraid of trying does your child try new foods? Do they enjoy trying new foods? Do they eat a narrow variety of foods? And I think there's a question around like mealtime behavior. So how are they at meals? Are they difficult to please or distressed at meals? All right. So let's revisit. So let's talk again about like other ways that we can define this pickiness. So, because like I said, this is one definition of like low, moderate, and high pickiness. One of the best kind of clinical definitions of pickiness that I have seen is from a clinician named Will Sharp, and he does a lot of research on eating and feeding disorders at the Marcus Autism Center in Atlanta. And he proposed a definition of pickiness that was really focused on not only how the nutritional kind of quality of a child's diet, but also started to pick up and tie in some other behavioral traits. But I'm going to focus here on how we would define kind of low, mild, moderate, or severe food selectivity based on the dietary quality. So I really like this definition because it's quite forgiving. There isn't like this super high bar for pickiness. And it has a really like good clinical utility or rationale, because the way that Will is thinking about selectivity here is really in terms of risk for nutritional deficiency. So when do we really need to be concerned about a child's diet? And the bottom line here is that what he proposes is that low levels of pickiness would be somebody who is probably preferential. They may even eat as few as 15 foods. Okay, so 15 different foods, but they're eating from all 5 food groups, at least on a regular basis. And he defines that. He's thinking of the five food groups as starches, fruits, vegetables, proteins, and dairy. So this means that they are eating at least a decent variety of foods from each of those categories. But again, the bar is super low. So just 3 foods from each category. But most foods from a child's diet may still kind of like cluster in one of those food groups, but they're eating at least a couple of items from all 5 food groups. And they're eating at least one thing from each of those food groups on a daily basis. So it may not be all of the foods from all of the food groups on a daily basis, but every day they're getting something from each of the 5 food groups. And he argues that this is low selectivity, one that we probably don't need to be super concerned about, because there's a very low probability of nutrient deficiency when a kid is getting something from at least a serving of from at least all 5 food groups on a daily basis. Moderate food selectivity starts to see a decrease in the frequency with which someone is eating from all 5 food groups. So this is someone who's consuming something from all of the food groups, but there may be some groups where there's only 1 or 2 items, so not a ton of variety within the group, but they are accepting at least 1 item from across all 5 food groups on a weekly basis. So this is a diet, he argues, that does lack diversity of certain nutrient-dense foods, and that further restriction would probably put them at greater likelihood of having nutritional deficiency. So this is like a child, perhaps, that if they jag, we need to be concerned about them jagging and dropping foods because they don't have a lot of backups from which to draw on. So this is someone, again, who's not at super high likelihood of being nutrient deficient, but they're really at risk because their variety is much more limited. Severe food selectivity would be evidence of clear nutritional gaps in a patient's diet. So someone who is rejecting whole food groups, so eating no fruits, no vegetables, no proteins, for example. But they may accept, and they may only eat like a very limited number of foods, so 5 foods. So that's not a lot of diversity of nutrients within somebody's diet. So this is somebody who's definitely at risk for having a micro or a macronutrient deficiency. And again, further narrowing of the diet would only exacerbate that risk or exacerbate the severity of their deficiency. Now, I mentioned that this is not just based on dietary variety, but this is probably the definition I like best of defining selectivity based on dietary variety. But we also need to consider those emotional and behavioral elements in determining level of picky eating or selective eating severity. So other studies who have looked at varying levels, low, moderate, and high of picky eating, have added in elements here of thinking about how the patient or how the child is functioning or the individual is functioning in their environment or with their family. So low levels of picky eating, while perhaps not very nutritionally risky, might also still involve some degree of impact on functioning. So whether that be social or family functioning, these are definitely individuals that aren't easy to feed, or it's not easy for them to find things to eat in their environment or to find meals that accommodate them in their environment. As we go up the ladder, though, moderate and high levels of pickiness or selective eating start to be associated with more physical or social impairment. So at moderate levels, we add in things like growth stunting or weight loss, and we start to add in greater risks for things like anxiety and depression. So we might start to see some more of that co-occurring alongside the pickiness. And then finally, at high levels of picky eating, we're seeing again the more extreme nutritional narrowing of the diet, but also seeing other behaviors, things like slowness with eating, experiencing early satiety, significant distress now present at mealtime. So for younger kids, this might look like tantrums at the table. For individuals who are older, this might be extreme anxiety when going out to eat or in eating in large groups, or when having to kind of eat a meal that is less preferred. There is also now clear growth impairment. High levels of selective or picky eating are also more likely to be associated with skills deficits, so oral motor skills deficits, as well as psychosocial co-occurring conditions, things like, again, anxiety and depression. And we find that even at very young ages, these high levels of picky eating are associated with these things, both concurrently and prospectively. We know that kids who are picky as young as 2 years old have high levels of pickiness, are more likely to develop anxiety and depression later on in their childhood years. So when we think about, again, categorizing picky eating, we need to think not only just about the limitations to someone's diet, but also the impact on their growth, their functioning, as well as thinking about their emotional things that emotionally co-occur with that pickiness. So let's go back to our case examples. A lot of you noted that with Lana, that this would be pickiness, more normative pickiness. And I think that's probably a safe conclusion to draw. While we don't know enough probably about Lana's dietary variety to officially say that it is, more kind of normative, transient, picky eating. This is something that probably could be just fine, right? She's dropped most of her veggies, but as long as she's eating a few and she's eating them on a regular basis, we wouldn't say that there's really any huge gaps in her dietary variety. Not trying new foods could be of concern, but also, as many of you noted, this is really developmentally normal in kids who are 3 years old. And she's still within that window, right, in which we might think that pickiness could be transient and get better. Switching preferences each week as well may or may not be a problem, depending on if she ever goes back to those foods, right? So if she's switching her preferences each week and she's not going back to some of those foods she used to enjoy, then that might be a different problem. So this is clearly pickiness, probably not enough information and low likelihood of it being a problem. And we just need to wait a little bit longer to see if these eating habits persist. Now, Chris, however, most of you noted that Chris's eating habits are most likely a problem, and we'll talk about ARFID here in just a second. But we're definitely seeing a much more limited, narrow range of foods. While we don't know the totality of Chris's diet, this does seem to suggest that probably at least on a regular daily basis, Chris is eating a limited number of foods from a limited number of food groups. They are dropping foods over time, so they're at risk for developing nutritional deficiencies depending on how much variety is currently present in their diet. Many of you noted the need to be pushed to eat, that they don't have a big competitive motivation, so we're seeing more other issues that are coinciding with their picky eating, and the shame and distress that they're experiencing about their eating habits. Not about the foods themselves, but definitely about the style of eating, which seems to suggest that this is probably a high level of selective or picky eating, most likely something that we would diagnose as being a problem. So before we talk about ARFID, because that is the problem that we are alluding to, sort of that when does that pickiness or selectivity cross over into being ARFID? I do want to kind of just share some broad conclusions about when would we start to be concerned about the pickiness or the selectivity. So when would we maybe not want to wait anymore to intervene or to do something about it? And I think conclusions that I've drawn across a lot of the research that I've read and a lot of the professionals I've talked to and in my own experience over the years is definitely we want to pay attention to variety. I tend to have a pretty, I would say, like high threshold for what I would say is a problem in someone's dietary variety. And that aligns with Dr. Sharp's definition, right? I think I see a lot of parents being concerned because their kid doesn't eat kale or Brussels sprouts, or they don't eat a really wide variety of fruits and vegetables. And I tend to be pretty satisfied, even if they're eating just a few different fruits or just a few different vegetables. But I think what's more important than like the number of fruits or the number of vegetables is looking at that frequency with which they're getting them in their diet. So being concerned if someone is not eating at least one thing from all five food groups on a daily basis. So maybe only eating from all five food groups a couple of days a week, right? Then we would maybe want to start to be concerned. Definitely when we start to see that impact on physical development, so losing weight or no longer growing, being small in stature, definitely not following a growth curve. I'd say a lot of my patients with ARFID trend on lower growth curves, but as long as they're still growing, we can watch it. But if they their growth curve starts to change or to flatten out or even begin to dip, we would want to step in. Struggling to eat enough food, period. So there's nutritional risk in just not eating enough. In fact, studies of kind of more transient, again, picky eating kids have found that there really are not a lot of nutritional deficiencies present in picky eaters compared to more typically eating counterparts. That, again, what we would more kind of like casually call picky eating isn't really nutritionally that different. But when we look at kids who are low weight, we do find that they are more likely to be nutritionally deficient. So not eating enough foods places somebody almost even more at risk for being malnourished. Refusing to try new foods is pretty consistently emerging as a red flag. So someone who's maybe lower in dietary variety, who also isn't exploring new foods or at least trying new foods, we might want to be more concerned about that person. Picky eating combined with tantrums or intense emotional distress. That one study of those, like the trajectory of picky eating that looked at the persistently low, moderate, and high picky eaters, did find that there were more kind of emotional problems in kids who were persistently high picky eaters. And then finally, I always like to put in here too that if you have identified that you yourself are picky or a kid is picky and you try to do something about it, whatever that might be, if things aren't getting better, even if you're trying to do something different about it, that would be another reason to seek out help. All right, before I go on to my next section, I'm going to check in here on questions. Um, Ricky. Yeah, Ricky, I'll get to the question about how if it's possible to have ARFID and be in a large body. We'll cover that in just a second when I go into the ARFID diagnostic criteria. At what age would there be cause for concern for eating at least one item? I would say at any age. So, but again, remember, it's like on that regular basis. So even in toddlerhood, if a kid is not accepting it, I tend to have a pretty broad definition of what would be kind of hitting all five food groups. So if somebody is eating pizza, for example, I might be apt to give them veggie for that. I know that we can all talk about Michelle Obama and her decision that pizza is a vegetable, but I tend to be pretty forgiving. So if foods kind of combine multiple food groups, I tend to count that. So I'm pretty kind of liberal or generous in my definition of whether somebody's getting something from all five food groups, but we're looking at, right, at least something from all five food groups on a daily basis. What about a child who manages to get food from all five food groups and enough, but only because the family is accommodating the kid's needs to have foods prepared in a very specific way and provide these foods in all situations? In that situation, Karen, where maybe we're not worried about the nutritional variety, but in that case, I would want to have a look at the family functioning, right? So is this putting a financial strain on the family to like have to eat at restaurants in order to keep their child nourished? How much extra work is it for the family to prepare the meals? And what would it look like if the family were to present a meal that was maybe the same thing that he did at a restaurant, but they made it at home instead? So I'd be looking at more of those like psychosocial factors, like what would happen if we stopped accommodating and how sustainable is that accommodation for the family? Let's see. I'm going to look at a couple of these questions over in the Q&A. Let's see. Hopefully, Celia, I answered the difference between selective and picky eating, right? It's the persistence there. Let's see. I'm interested about the phenomenon of super tasters. Sean, we're going to talk about super tasters, so I'm going to save your question for a little bit later. I love talking about super tasters. For patients who find that picky eating label is negative, I change language to having strong preferences. I would agree with that, Caitlin. I like to think of picky eaters as being preferential eaters. They do, and that's nothing wrong with having strong preferences. We all have strong preferences around food. Somebody who gets classified as being picky or selective just tends to have more of them. So I think strong preference is a great way to talk about someone who is picky. How do we determine the difference between pediatric feeding disorders versus ARFID? Christina, I'm going to talk about that one here in just a second. Yeah. Okay, Emily, we'll talk. Maybe let's save the question about Chris and their gender identity for the end, because we can definitely follow up on that. All right, I'm going to move ahead then to ARFID. Okay. So what happens when this pickiness is taken too far? So we can think about Chris's example, or think about those high, persistent, picky or selective eaters. This is when we would classify someone as having ARFID. And I would argue that anybody who is at a more severe level of selectivity, persistently selective, meets the criteria for ARFID simply based on the fact that to be considered severely selective or picky, there has to be some sort of impairment in functioning. And so these are individuals that would meet criteria for ARFID. So what is ARFID? Just to level set for everyone here, since I'm not sure what level of familiarity all of you are coming in with when it comes to ARFID. ARFID stands for avoidant restrictive food intake disorder, and it is an eating disorder that is characterized by problems with either volume, so not eating enough food overall, or variety, not eating enough different types of food. And the eating disturbance is not driven by a desire to lose weight, a fear of gaining weight, or a desire to change one's body. And I always like to take a second here to qualify that this does not mean that patients with ARFID can't also have appearance dissatisfaction or body dissatisfaction. We all live in a diet culture. Diet culture impacts all of us to varying degrees. So someone with ARFID, it doesn't mean that they don't have concerns about their appearance or their body image. It's just not the driving reason for their eating behavior. Their eating behavior instead is driven by something else. And those things are a fear about the negative or aversive consequences of eating, a lack of interest in food or eating, or sensory sensitivity that contributes to selectiveness. So ARFID can be caused by or driven by one or more of these things. Someone with ARFID may struggle in one of these domains or in all three of these domains. So we're primarily here talking today about ARFID that is presenting with selectivity driven by sensory sensitivity. But I do like to acknowledge that ARFID is not just selective or picky eating. ARFID can be things like having a specific fear of vomiting or a specific fear of choking, or by somebody who just maybe they eat a variety of foods, but they just don't eat a lot of food and they're not super driven to eat. So these are individuals who are just fine going long periods of time without eating. They tend to get full really early at meals, even if they haven't eaten for quite some time. Or they just don't find food that enjoyable. I worked with a young boy once who ate a very narrow range of foods, but who also he didn't find food really enjoyable in the way that like I find food enjoyable. And I asked him once, tell me, on a scale of 1 to 10, like how much do you enjoy your favorite food? So what is your favorite food? How much do you enjoy it? And 10 being, I could eat this all day, every day. 1 or 0 being like, never, I don't want to touch it or ever eat it at all. And he responded that he liked his favorite food a 3 out of 10. That's how much he enjoyed eating his favorite food. So that's lack of interest. Now, what then, again, differentiates this selective eating that we've been talking about, right? Where there's a limited variety from ARFID, and when does it cross over? And as hopefully all of you can answer now, that crossover point is the point at which the selectivity starts to cause problems. So to meet criteria for ARFID, you really have to have one or more of these following things here. So it's not enough you can't be diagnosed with ARFID just because you're picky or just because you have some concerns about the outcomes of eating. One of these things has to be true along with that. So either you need to show weight loss or a failure to grow. You need to show a nutritional deficiency, which we're going to talk a little bit more about this here in just a second. You need to show that you are dependent on enteral feeds, which are tube feeds, so either an NJ or NG or a gastronomy tube, or oral supplements. So this could be Boost, Ensure, Carnation Instant Breakfast. So for example, you could have somebody who is selective, but they don't have nutritional deficiencies and they're growing just fine. They're not underweight. However, maybe they get the majority of their intake from like a liquid supplement, like a Booster and Ensure. And if we were to remove that liquid supplement from their diet, they would then become nutritionally deficient or begin to lose weight. That's dependence. And then finally, you can meet criteria for ARFID if none of those are true, but you simply are your eating simply causes problems in your daily life, whether that's emotional or social or occupational. So in kids, this might be, right, this inability to socialize. You can't go to birthday parties, you can't go to sleepovers because you may not be able to find something there that you like to eat, or going to a birthday party or sleepover means you don't eat at all. Your family may not be able to go on vacations because there's a risk that you might not have access to those foods that you eat on a daily basis. Or because I've seen this in other cases where they may eat a preferred food that, like, for example, their parent makes at home, but when the parent makes it in a different kitchen, in a different house, in a different environment, or if it's prepared at a restaurant instead of at home, they can't eat it. In teens and adults, we see problems with dating and making friends, some more increased loneliness. There was an adult I worked with once who was in his late 30s, and he ate only a few different foods, but he never left his house. He had no friends, all because of his worries and concerns, both his shame and embarrassment about his eating habits, but also his inability to eat things that were prepared outside of his home. Um, so ARFID, again, just really want to make sure I emphasize that last point because a lot of people think that you need to have weight loss to be diagnosed with an eating disorder, or that there needs to be this clear nutritional deficit. There are lots of ways to avoid these first three things, but still have your eating cause a lot of problems for you. So this is the point. This is the crossover point when somebody's eating has gone so far that at least one of these things has resulted. Now, what is the difference? Now, we'll talk a bit. I'm gonna jump around just a second, but I do want to talk about, again, some other things to know about ARFID. ARFID is a relatively new diagnosis in the DSM, and it has replaced the DSM diagnosis of feeding disorder. We'll talk about the ICD diagnosis of feeding disorder in just a second, but ARFID, I want to make sure everyone is aware that it has no age limitations. This is one reason why we got rid of feeding disorder in the DSM, because with feeding disorder, you had to show that it onset before the age of 6. ARFID can onset at any point of life, or for example, may not be a problem until much later in life. So there's no age limit. It is a lifespan diagnosis, emphasizing, again, no weight loss or growth impairment required. And it can exist within the context of another medical condition. So it used to be that this was an exclusion criteria for being diagnosed with a feeding disorder. There are many medical conditions in which we see an impact on eating. And so ARFID can be diagnosed in the context of a medical condition when the impact on eating kind of goes above and beyond what we might expect. Great example of this might be like food allergies or various gastrointestinal disorders that might require a person to make a change in their diet or to limit their dietary variety. And then the person takes that limitation too far because of growing anxiety about the outcome or the impact on their GI system. Okay, so how would we define selectivity in terms, or how can you assess for that selectivity in terms of determining if somebody is at risk for a nutritional deficiency? Because this usually is the first and foremost concern here when we're dealing with selective eating. So As a provider, I really like to partner with dietitians. So I find that my dietitian counterparts, my dietitian peers, are incredibly helpful in helping me assess kind of the adequacy of a person's diet. However, a dietitian is not required to make a diagnosis of ARFID. So I do like to talk about some tools for helping you kind of estimate someone's nutritional adequacy. Now, the best way to determine if somebody is nutritionally deficient is to do blood work. Um, Now, sometimes I have found that physicians might not be willing to do this blood work, or I suspect that a nutritional deficiency might be present, but it doesn't show up in blood work. It's really easy to kind of not be diagnosed with a nutritional deficiency. For example, if you take a multivitamin or if you eat any foods in your diet that are vitamin fortified. Other ways to kind of determine this part of the requirement too is by kind of estimating the nutritional adequacy of somebody's diet. So you can do this in really, really sophisticated ways and some kind of really blunt force ways. So food frequency is a great way to determine whether or not somebody is meeting their nutritional needs. So Will Sharp's definition of selectivity was definitely written in terms of food frequency. And there are assessments that are food frequency assessments. And so food frequency assessments, and my dietitian colleagues who are on the call today, feel free to correct me if I get any of this wrong. But food frequency assessments are typically these really exhaustive lists of different kinds of foods. This is an example of one here. This is an excerpt from a food frequency assessment. And you're really just noting how frequently you consume these things. Never less than once a week, 1 to 3 times a week. There are a number of different ways we can measure that frequency. For some of these assessments, these are assessments you need to pay for. There's really sophisticated software that can measure or analyze the assessment to, again, help you identify any kind of dietary gaps or holes in a patient's diet. I use a frequent version, and at Equip, we use a frequency of a food frequency assessment that's more pencil and paper. So we've kind of developed it based on like other assessments that are out there. And we simply just ask our parents or our patients to go through and note how often they eat this. I eat this never, I eat this sometimes, or I eat this always. And we find that it's a really kind of quick and easy way to identify gaps and to see, again, estimate that question of, daily or weekly basis. How often is somebody eating from all of their 5 food groups? How many foods do they have in each of the 5 food groups? There are other ways to do this too. You can have patients do recalls, so like a 48-hour dietary recall or a 4-day dietary recall, where you have people keep logs of everything they ate and the volumes or the measurements of it. In 2 of our treatments for ARFID, FBT and CBTAR for ARFID, there are tools. The primary food groups building blocks, which is in the CBTAR manual, is kind of like a food frequency questionnaire, so you can use it in that way. And then in FBT, we ask our patients and families to keep track of what's called their always, sometimes, and never list, which is a list they make themselves of the foods they always eat, sometimes eat, and never eat. So it's another way to kind of estimate this. Now, the reason I like a food frequency assessment more than like a dietary recall or an always, sometimes, never list, just for me personally, is that it's just so easy for me to identify the gaps because it's already organized in terms of the food groups. But any of these things are ways that you could go about beginning to determine how selective your patient really is and whether or not there are any gaps in their diet. Um, Other things though to take into consideration here, because again, I find in practice and here at Equip, it's not really regular or often that we're coming across cases of true nutritional deficiencies that's like diagnosed by a blood test. Although absolutely in the literature and in practice in other clinics, they are seeing cases of scurvy, seeing cases of rickets and like really like severe nutritional disease associated with selective eating. But I also like to think about this, like I said, in terms of risk. So maybe their diet's adequate, but I also like to think about, the risk for food jagging. Maybe they have 3 or 4 foods, but what if one of them they're starting to eat less and less of? What's the risk if they were to lose or drop out one of the foods? And do they have a history of jagging? I also like to think about functioning here, though. So, are the foods that they eat foods that they can eat in any environment, in any context? Can they eat it if other people prepare it and not just themselves or their parents? And as always, of course, weight and growth status, which is a really, really kind of great indicator of nutritional status. If somebody has lost weight, relative to where they were in their development, or if they've been persistently low, like way below those growth curves in their development, that's another good sign of malnutrition and nutritional status. Quick example of food jagging is when you have a food that you eat all of the time and then you get tired of it or you get sick of it. So apologies for using that terminology. It's so natural to me now, but like a great example is like, I think I went through like a period of my life where I ate cereal like every morning for breakfast, and like it was my go-to. And then all of a sudden one day I was like, I am so over cereal. And like, I don't eat cereal for breakfast anymore. Haven't since. That's a food jag. And food jags could be permanent or they could be temporary. Sometimes people pick foods back up that they've jagged on, but sometimes they don't. I do, yeah, like flavor fatigue. That's a great example. Sorry. I do want to emphasize here too, though, that like this like nutritional adequacy aspect of the diagnosis can be really hard to meet. Like there really needs to be a really high level of selectivity to meet this. And the research shows that while ARFID patients do have differences in terms of their overall like macro and micronutrient consumption compared to peers with ARFID, the clinical significance of those differences, though, is pretty questionable. Oftentimes, while there are differences, they may not be like differences that are actually making a difference in that person's functioning, or that we would, like I said, would be clinically significant. So, all right, moving on. So feeding disorder, selective eating, ARFID versus a feeding disorder. And so note here that I'm noting ICD. So while feeding disorder is no longer a DSM diagnosis, it is still an ICD diagnosis. And there is a lot of overlap between these two diagnoses. So when you look at the ICD criteria for a feeding disorder, and the DSM criteria for ARFID, there's a lot of sameness there. A feeding disorder, in addition to somebody's eating habits being eligible for a feeding disorder diagnosis because of growth impairment or because of psychosocial impairment, a feeding disorder could also include there's like a medical condition that is primarily responsible for the feeding or the eating difficulty. So something that either is preventing a person from being able to eat, or that has substantially impacted or altered their ability to eat. And then somebody who, it also could be due to an oral motor skills deficit. So somebody who has not properly developed, either for a number of reasons, the ability to chew and swallow and manipulate food in a safe way that allows them to consume a wide variety of textures. This could be due to like prolonged or extended tube feeding, due to being born premature or from early medical problems. Or because of early childhood neglect, or just a lack of early exposure to different textures or tastes of foods, and they just never developed the oral motor skills needed to be able to chew and safely swallow more difficult or complex textures. So when I consider whether something would be a feeding disorder or an ARFID diagnosis, these are some of the things that I think about. And I will just say again, there is no clear consensus on when you would diagnose. For in cases where there's growth impairment or psychosocial impairment, there is no clear consensus about when you diagnose ARFID or when you diagnose feeding disorder. I'm part of a team that's actually trying to work on that consensus right now, because there's still a lot of disagreement between our eating disorder colleagues and our feeding disorder colleagues, and even within the feeding disorder community on this issue. But in general, I'll say the way myself and most of my colleagues approach this question is that if there is a skills deficit, so if a child is lacking some of the basic skills needed to chew and swallow food, either due to developmental reasons or medical disruptions to their feeding and eating development, I would diagnose pediatric feeding disorder. Christina, great question, whether or not you can be diagnosed with ARFID and PFD. And I will say jury is absolutely 100% still out on that. I think that potentially yes, but it all depends on how we define pediatric feeding disorder. So a question for another time. Stay tuned. Remember that more severely selective children are more likely to have accompanying oral motor skills deficits. So this is always something I like to screen out for, particularly in younger children. So while ARFID can be diagnosed at any age, we can assess for ARFID in children at least as young as 2 years old. I am much more apt to consider a differential diagnosis in children under the age of 5 because they're still within that developmental window for acquiring all of the skills that they need to be able to eat and feed themselves. So, if I'm seeing highly selective eating in a very young child, I am absolutely going to want them to be evaluated for a pediatric feeding disorder by a speech language pathologist or an occupational therapist. All right, so to sum things up before we move on to treatment, is this pickiness or is this a problem? So pickiness, I would say, is having strong preferences for specific types of foods, potentially even strong preferences for brands or certain preparations of foods. However, this is a person who may or may not try new things. Maybe they try things and they don't like them, but they'll try. And they're eating from at least all 5 food groups on a regular basis, even if it's not a lot of foods. And the bottom line is that someone who I would call picky and not ARFID is most likely growing okay. And their eating doesn't cause too many problems. So I'm not saying that a kid who is picky is like easy to feed or easy to kind of fit into your family's kind of feeding culture. But it's manageable. It's not causing hardships. It's not negatively impacting the parent-child dynamic or relationship. And I put an asterisk here too, because I think this is when we judge this, I think we need to be really, really aware too of just cultural context and factors. We need to think about this from the lens of a family's environment, a family's culture and their lifestyle and where they live and how they define kind of their expectations related to eating. ARFID is when we see, again, strong but even narrower preferences for types of foods, brands, and preparations. We're seeing perhaps exclusion of whole food groups or not eating from all 5 food groups on an or eating from all 5 food groups, but on an infrequent basis. Refusal to try new foods, perhaps not always, but definitely more common here. But the biggest distinguishing factor, again, is impaired growth, health and social consequences, and emotional distress. Um, so I'm going to pause here again, and I'm going to look back through comments and questions. Going to go over to the Q&A first. So Jasmine asked, do you see comorbidity with ARFID and OCD in your patients? Absolutely, particularly within our patients who have ARFID due to fear of aversive consequences. We are most likely to see that overlap with OCD there. Not always, but definitely higher rates of OCD in our ARFID population compared to like a child without an eating disorder or an individual without an eating disorder. Kim, is there a specific age kids need to be in order to be classified as ARFID? Again, there's some debate here when you talk to feeding colleagues, because again, I think if you're looking at a diagnosis under the age of 5, you really have to consider whether or not there are deficits or delays in the skills needed to be able to eat and feed. If you have ruled those out, absolutely, you can diagnose ARFID under the age of 5. The assessments, again, that I've seen, there is one assessment, the PICA ARFID rumination disorder interview, that does go down to age 2. A minimum duration of symptoms needed to be present before the diagnosis. The DSM does not specify a minimum duration of symptoms. They mention persistence, but how we define persistence is sort of up for interpretation. So no guidance on how long symptoms need to be present in order to make the diagnosis. What blood work should we recommend to the MD to consider for nutritional deficiencies? I usually like to partner with the MD on this, or again, I will ask I will ask one of my RD colleagues to step in. So I may talk to the MD about where I'm noticing nutritional gaps or the fact that I am observing nutritional gaps, and I will defer to the MD as to what labs that they would want to run to check for nutritional deficiencies based on the diet for the child. Um, Hillary, is food jacking more common with ADHD? That is a great question, and I don't know the answer to it. I don't think that we have data on the prevalence of food jacking specifically within the ADHD population. But I love that question because of, I think, the differences we see just in reward processing in that population. So it's a great question, and as I said, I don't know the answer to it. Okay, let's see. I'm going to go over to the chat now to check for questions. Somebody's asking, where's the RD as part of this presentation? We don't have the RD as part of this presentation. I work incredibly closely, and I have over the past 10 years that I've been working with and treating ARFID to develop a lot of my understanding and approaches. So I would absolutely say this presentation is RD informed, but we don't have the RD present with us today. My assumption is that a psychologist, yep. Absolutely. We're really kind of focusing here on more of those diagnostic differences. Let's see, an FFQ can be overwhelming. And for any young clients with co-occurring comorbidities and or cognitive challenges, it can be a lot to comb through. Absolutely, Victoria. The FFQ is very overwhelming. Typically in children, I'm having parents complete it. The always sometimes never list. The reason I tend to prefer an FFQ over the always sometimes never list when I'm trying to determine nutritional adequacy is because what I often find is that parents are able to identify more foods that their child eats with FFQ as opposed to always sometimes never, because always sometimes never relies on recall. So parents have to remember what their kid ate, whereas the FFQ relies on recognition. So I usually pick up on more foods when I use the FFQ than when I'm just having parents write things down from memory on an always sometimes never list. So that's why, at least at the beginning to do assessment, I prefer an FFQ. It's oftentimes very surprising because both for myself and for the parents, we find that variety is actually better than we thought it was going to be, or it then becomes a great basis for brainstorming like meal composition moving forward because we have the FFQ to kind of pull from. All right. We talked about being diagnosed with both ARFID and PFD. Do we think OT would be helpful for adults with ARFID as well? So Christina, yes. Short answer is yes. And we'll talk about OT in just a second here because the next section is going to be all about treatment. In terms of ADHD and ARFID, how do we determine whether it's a combination of the extreme food selectivity and or the medication decreasing appetite? Fantastic question. So this is complicated. What I find is that ADHD medication, like I said, has more of an impact on overall intake, not necessarily variety. That is just in my experience, and I don't have there isn't, as far as I'm aware, any data out in the literature to support that more systematically. But a very significant majority of kids that I have worked with and adults with ARFID have ADHD. Estimates from previous clinics I've worked at have been about 35% of our patients have had co-occurring ADHD. And again, I find that the impact is mostly on overall volume, not necessarily on variety. And then as to the role of medication, just as we consider treatment, my experience typically is that we still need some of that ADHD medication in most cases. But we often have to, for example, add an additional medication to help counteract the negative impact on appetite in order for it to be successful. Are these assessments proprietary or free to use? Alicia and Margaret both asked questions about the assessments. The PICA, ARFID, and rumination disorder interview. There's also a questionnaire version. Both of those are freely available. If we have time at the end there, I'll try to go grab the link for those, and if not, I can perhaps have Haley include that in her email, but I'll try to grab the link and post it in the chat here. Food frequency questionnaires. There are a lot of different ones out there. Some of them you have to pay to use, and they are expensive. And as I mentioned, they have like a software that accompanies them that helps with doing the analysis. The FFQ that I put together is sort of one that I've built over the years based on various ones I've found online. There's really like no right or wrong way to do one. I recommend that if you want to find one or put one together, that you partner with an RD to figure out. Oh, thank you, Elizabeth, for putting the link to the party up there. I appreciate that. To help you make sure you have one that's extensive enough. You could also use the one, as I mentioned, from the CBT for ARFID manual. It has an extensive list of foods in there. It's to help with planning dietary expansion, but you can use it the same way that you would use a food frequency questionnaire, and it's very comprehensive. All right. Catherine. Oh, hi, Catherine. Dalsgaard. What are the meds added to counteract stimulants and appetite suppression? So I'm going to say I'm not a psychiatrist, so I am not here to give any advice on this. I would say that my former colleagues and I recently published a study on the treatment of co-occurring ARFID and ADHD in kids. And what we found is that almost all of our children who were diagnosed with both, who went on to be successfully treated, they typically had the medications that were typically prescribed alongside their stimulant medication were either Remeron or mirtazapine. Or Zyprexa, which is a medication we often use in the treatment of anorexia nervosa to help with weight gain. Right. Okay, I'm going to move on to treatment so we make sure we have enough time for this because we are running low on time. So it's 10:37. We've got about 23 minutes left here. So treatment of selective eating. I like to kick this section off talking a bit about what we know causes selective eating. And TLDR is that there are, as I'd say, it's like jury's still out. And that is because it's complicated. Taste is complicated. So in the ARFID world, one of the kind of most well-received and widely used models of potentially how ARFID develops, and this is a hypothetical model or a theoretical model right now, is that the selectivity we see in ARFID is primarily driven by sensory sensitivity. So this would be thus that ARFID is caused, or ARFID with selective eating is caused by disruptions in our perceptual systems in our brain. But one of the things I like to emphasize is that taste is so much beyond just suppression. So we could talk about taste at like the receptor level. Somebody brought up super tasters before. So this is one way that for example, one group of researchers at Harvard at MGH is studying sensory sensitivity as it relates to ARFID, as they're looking at this concept of super tasters. And they have this theory that a super taster is potentially more likely to be diagnosed with ARFID. Someone who is a super taster has a higher density of taste buds on their tongue. So in theory, they experience flavors more intensely because there's just more sensory input coming in. I believe that their data, though, has not yet supported this finding. And if you go down like the rabbit hole of taste literature, you'll find that like information that we have about super tasters is pretty inconsistent. Sometimes these are people who then prefer more bland foods and bland diets because of the sensory overwhelm. But sometimes they are the more adventurous eaters who seek out a lot of different types of taste input. And I put this figure up here because taste is not just what happens at the taste bud receptor level. There is input and processing that goes on in our emotional center of our brain. So there's an emotional and hedonic response to food that gets combined with the sensory information. There is information coming in from our centers of the brain that regulate our appetite. There is information and input coming in from the parts of our brain that are responsible for initiating or stopping eating. So there's lots of layers here to our experience of taste, and it's so much more than just what happens at the level of our taste buds. It's not just the information coming in, but how we interpret that and how that information kind of gets mixed up with different parts of our brain and that are really responsible for, again, the act of eating. So it's not as simple as what is happening down at the sensory perception level. There are lots of things that go into the development of our food preferences. Genetics plays a big role here. So for example, our ability to even detect certain flavors in food is genetically driven. In fact, one of the ways that we defined a super taster is whether or not somebody has the ability to detect a very specific chemical compound called, I think it is theoreus. So if any of you ever did those like little taste strips when you were like in middle school or high school science class, that's a super taster test, and that is to see if you can detect this very specific chemical compound, and that is again genetically driven. People who are able to detect this compound tend to not enjoy things like salads or dark leafy greens. They're less likely to like coffee or like dark beers, things like that are more bitter in nature. There are also other innate predispositions. So, in general, as humans, as a species, from very early on, we tend to have a propensity for high fat, high sugar foods. A preference for salt also emerges at very early ages. And that is because, again, these are some of the most energy dense foods. And these are things that tend to sort of cross-cultural boundaries as well, which again kind of goes back to there are some just biological forces at work in the foods that we pick. But physiology plays a role, how we respond to the food that we eat. Foods that tend to give us more energy tend to be more rewarding or pleasing for us. And so again, that's high fat, high sweet foods. The energy density of foods also seems to predict our liking beyond just the flavor of food. So we can vary the flavor of something, and the energy density of a food will be more predictive of liking than just the flavor itself. Our hunger states determine liking. Our experiences of disgust. So while we think of disgust as an emotion, disgust is a very physiological experience. So if somebody eats something and has a strong disgust reaction, they are very likely to form an aversion to that food. And many times that is an aversion that will stick for life. So if any of you have ever gotten food poisoning and connected that to a very specific food or meal, you may find that, right, you can never eat that meal or that specific food again. That's how strongly disgust can influence our food preferences. Um, Cultural norms and familiarity. We also tend to prefer foods that we are familiar with. So sometimes this is culturally driven. So some cultures enjoy much more. Sometimes some cultures have foods in general that are more heavily spiced as part of their cuisine. And children from those cultures tend to have a higher preference for, tolerance for spicier foods or more heavily spiced foods. But even at the household level, your kids are more likely to prefer and be willing to try foods that they see on a daily basis and that they see being eaten on a daily basis. Early exposure matters a lot as well. So I would say it's more so than just exposure, but early repeated exposure. I was one of those parents. I think I did baby led weaning with my second child and really wanted to expose them to all of the things. But like the foods that stuck are the foods that we were more likely to normally eat as a family. So like my kids both ate sweet potatoes when they were being introduced to solid foods, but we're not a big sweet potato families. I never buy sweet potatoes. We never prepare or serve sweet potatoes. So like that one didn't stuck, even though they had early exposure. And then there are personality factors. So in general, and I don't know how much I like these terms, but in general, picky or eating or more narrow food preferences are linked to more emotional temperaments. But also to thinking styles. So, cognitive like flexibility or lack thereof, so rigidity, has been linked to more persistent selective or picky eating and narrower preferences as well. So, bottom line here, taste is complex. Um, what we have found is that of all of these factors, there are certain ones that are now starting to be linked to the type of selective eating or to the severity of selective eating that we associate with ARFID. And I like to consider these things because these things then inform how we intervene or treat. So while sensory perception, differences in sensory processing have definitely been linked to the selective eating in ARFID, Other factors are also seeming to play a big role as well. Cognitive rigidity has been linked to selective eating in ARFID, and in some ways has been shown, and in one study was shown to be more predictive of selectivity over sensory perception or even anxiety around food or eating. Disgust. So, individuals in particular who tend to experience disgust more frequently. So, there are kind of two variables we look at with disgust. We look at disgust propensity. So, this is, again, how frequently you tend to be disgusted, and then disgust sensitivity. So, that's like your emotional response to disgust. And it's the propensity that seems to be more strongly associated with ARFID. So, our patients who have selective eating and ARFID are people who individually tend to experience disgust more often. And then food neophobia, so a fear of trying new foods, which is one of those personality traits that has been connected to taste preferences as well. So individuals who are more fearful of new things or of unknown things are more likely to have ARFID. So some of these factors, perhaps you're putting kind of pieces together, are part of why ARFID has been so, or selective eating has been so strongly linked to neurodivergency. Sensory processing is one domain of neurodiversity, as well as cognitive rigidity or flexibility. That is also a domain of neurodiversity. And while neurodiversity is not solely limited to autism, staggering up to 89% of autistic children have feeding differences. So this partly explains why. Another kind of just interesting point of overlap that we see that might explain the relationship here, or the high degree of overlap, is the co-occurrence of gastrointestinal issues, at least in autistic individuals. So autistic individuals have, on average, a higher incidence or higher co-occurrence of gastrointestinal issues, which contribute to having painful or negative experiences with food. And remember how I said our physiological reactions inform our food presence. If you are somebody who has had, in general, more painful or uncomfortable experiences with eating, you are probably going to be less inclined to eat or eat a wide variety of foods. All right. Now, there are two other factors that I think are important to mention in regard to development. The first, and these are both factors that have to do kind of on the caregiver end of things, and that is accommodation. So we do know that parental accommodation is more strongly linked to picky or selective eating. So accommodation meaning that, we recognize our children's preferences and we adjust our lives accordingly, right? So we prepare alternate meals for them. We don't persist with foods that they reject. We don't offer foods again. We allow them to not eat foods that they don't like. That's accommodation. And that is linked with picky eating persistence, with selective eating. Also, pressure to eat, though. So this kind of pressure to focus on liking foods, which I think, very instinctively do as parents. But also sort of use of more judgmental language when trying foods, expressed emotion, so that frustration, that criticism, that anger that we might get when we get frustrated with our kids when they don't like things, overwhelm, so serving too much of something too frequently, having too high of demands on expectations for eating, greater restriction, which places kind of an indirect pressure on eating. So removing certain foods from the house because you're trying to get your kids to start to sort of naturally kind of veer towards other foods that you would prefer them to eat, and demanding this. These are all linked to picky eating or selective eating. But I would ask all of you, as you consider these two factors, to really withhold judgment of parents and caregivers. These are correlational relationships. They are not causal. And in my opinion, I do think that accommodation and pressure to eat are both very reasonable responses to persistent pickiness in a child. So I think we just need to remember that this is not an indication of a directional relationship, just things that tend to co-occur together. Okay. So I apologize. We have 11 minutes left. And so I want to get through this, and everyone is able to request the slides. We'll make them available after today's talk. But I always like when we talk about treatment to address when to treat selective eating, particularly in the context of ARFID. I am a person who is very much in line with the style of treatment, the order of treatment outlined in cognitive behavioral therapy for ARFID, that says we save dietary expansion work for last. I often find this is some of the hardest work to do, but it's also some of the work that is best done after we've addressed other factors. So I always like first to make sure that a patient is getting enough to eat. So we correct issues of growth and overall volume of eating first. We make a plan then for when and how we're going to start dietary expansion work, but address other things. So any specific fears, any volume intolerance, any other appetite issues before starting dietary expansion. And when it comes to this work, there are kind of three, I'd say, sort of domains of treatment for this. Feeding therapy is one domain in which selectivity is often addressed. And under kind of the umbrella of feeding therapy, there are very specific and different approaches. So, feeding therapy could include behavioral intervention, like applied behavior analysis. There's a very large evidence base to support the efficacy of behavioral interventions for the treatment of selectivity in young children. The sequential oral sensory approach is an approach used by occupational therapists to help with progressing the sensory tolerance of different foods. And then there are other kind of classes of approaches to selective eating or to feeding, just in general. I should say it's not specifically for selective eating, such as responsive feeding or the Satter division of responsibility approach. These are any number of offerings that could be offered within the context of feeding therapy. Um, Now, none of those, so SOS specifically, responsive feeding, division of responsibility, none of these have specifically been evaluated on a research level, kind of on a systematic level with ARFID. There is limited data on the use of them within specific feeding problems. Behavioral intervention, though, far and away has the most empirical support and has been the most widely evaluated. So Kiara, you mentioned speak to the way these can be used with adults. These are not interventions that I have seen used with adults. They may be used in practice, but we absolutely don't have data here. And behavioral intervention, especially, I have not seen evaluated in children above the age of 7 years old. So these are not interventions that I would recommend as a first-line approach for adults. Now, two other treatments for ARFID, family-based treatment for ARFID. It's, again, a family approach. This one has been used in children between the ages of 5 to 12, anecdotally, because ARFID for anorexia is used in teens as well as young adults. I have seen some people use FBT ARFID in older patients with ARFID. One of the downsides to FBT, I like FBT for a lot of reasons, and one of the downsides is that it doesn't give a specific approach to expanding dietary variety. That could be a good thing or a bad thing if you are someone who is used to, what I do like about this is that there are, I think, a lot of really great approaches and strategies out there for expanding dietary variety. I don't think our data necessarily favor any specific one. And so FBT allows you to use the one that feels the best, the one that seems to work best for a family or that a parent prefers, which can be great, especially when getting your foot in the door to get parents engaged in treatment. So there's a lot of flexibility there in how you would approach the expansion of dietary variety in FBT. CBT for ARFID is the only manualized treatment for ARFID that has been evaluated in adults. In fact, I have only seen data on the use of CBT for the treatment of ARFID in adults. So this is what I would recommend as a frontline approach to working with adults with ARFID. I do think anecdotally we are seeing more, for example, OT work being recommended for adults. I think OT can be a great adjunct and augmentation to a CBT-AR approach, especially if you have an adult who has a lot of sensory challenges. And CBT, they do have a very specific approach to how to help with expanding dietary variety. And I do think it's important to note that the approach that CBT uses for expanding dietary variety is actually based on the SOS approach to feeding. So the sequential oral sensory approach to feeding, and also combines it with mindfulness techniques to help with establishing non-judgment and open-mindedness and willingness to trying foods. All right, for the sake of time, I'm going to move on. And one of the things I want to spend a lot of time on here is what I would consider to be sort of several grounding principles of expanding dietary variety. And I've got a picture up here of one very popular person right now in the world of ARFID, which is Hannah. So I don't know if any of you follow my ARFID life on Instagram. I discovered Hannah back in early February, and I love, love, love her account. I bring her up here because I actually find that Hannah's approach to trying new foods is really consistent with all of these principles. So I think she's a fantastic example of one way to approach expanding dietary variety. So I'm a big Hannah stan. Um, the four kind of principles that I, and many of my colleagues, I've drawn on this from literature and my work with other peers, is that dietary expansion work needs to be patient-led. So patients need to be driving the dietary expansion work. This is not something that I think goes very well when we impose our preferences for dietary expansion on patients. Now, I do think there are some developmental considerations for working with children, the same way that I think children, we don't put medical decisions in the hands of children. I think when we're dealing with children who do have very serious and life-threatening nutritional gaps in their diet, we do need to have some element of kind of working with the child to sort of point them in the right direction. But in general, when it comes down to the exposure, I want the patient to be on board. So this needs to be patient-led to the extent that it is possible to have it be patient-led. Also, eating is essential. And maybe that sounds like it should go without saying, but there are some feeding approaches that really make it optional whether or not you eat. And you can't learn to like a new food unless you eat it. So eating absolutely has to be part of dietary expansion work. Next, try again, repetition. But you can think about this both in terms of repetition, but also variety. We oftentimes, what I find, so there's lots of stats out there, right? Like you have to try a new food 15 times before you know if you like it. And I think it's not super successful to stick to that number and so make a patient try something 15 times. What I feel like that number more underscores or illustrates is that often that first taste is really more of a reaction to the unfamiliarity or newness of a food. So you often need several tries to sort of get over that hump of something being a totally new or different sensory experience for you. It's kind of like jumping in a cold pool, right? That shock at first is like really like off-putting, but if you stay with it long enough, you kind of adjust and get used to it. So you need to have repetition in order to overcome the newness. And this is what Hannah like does so well, right? She has this, I have to try things 3 times. And she even explains it in one of her videos why she does it. And it's because, right, the first time is kind of just like that shock and you have to get over the shock and keep going. And then finally, taste before incorporation. I tend to recommend and prefer that tasting new foods happen outside of the context of meals. What I find is that often by having tasting work happen at meals, it can sort of poison the rest of the meal. So the patient, especially if it's a food that is very difficult or distressing or hard for them, may not eat the entire meal if there's a new food on the plate. You also run the risk of, if the tasting is at the end of the meal, you now have somebody who's full going into trying a new food. And we know that hunger influences liking. So if somebody is more full, they are going to be less likely to like or prefer a food. So for both of those reasons, I like for tasting to happen separate before it starts to be incorporated into a meal or into somebody's regular diet. I so apologize because we have run out of time. The rest of my slides do cover some various strategies for helping with this dietary expansion work, including how to set reasonable expectations or modify expectations with patients or with caregivers so that your work can be more successful. Strategies and tips for modifying caregiver behaviors, the ones that I usually hone in on. I'll tell you just a little bit about the panda example. This is one I definitely took from my colleague Hannah Zickgraf, to help parents understand why patients with ARFID sort of left to their own devices won't just naturally start to choose new foods. And so pandas are an animal that eat exclusively bamboo. And if you deprive pandas of bamboo, they will starve to death. They won't just find something else to eat. And that's a lot like our ARFID patients here. They will not just naturally find other ways to eat. And then finally, I talk a little bit about the exposure work itself, how systematic desensitization works, and just some tips for how to approach these exposures, really kind of keeping your expectations low, really encouraging any entry point possible for a patient, trialing lots of things, because when you have someone who has a really high rate of failure, you've got to get through a large volume of different foods to try so that you can actually have a better likelihood of landing on foods that will stick. And then finally, getting creative with it. I am a fan of vegetables in whatever shape or form a vegetable comes in, whether it's in a juice or a smoothie or freeze dried or whatever. Like, be really open to how you get these new foods introduced to a patient. So, um, takeaways for today. I'm happy to stay on for a few minutes and answer questions if people are open for doing that, but really just appreciate all of you attending today and being willing to be here. And maybe we will continue the conversation in another presentation down the line. So thank you all so much. Right. So as everybody's leaving, I'm just going to hang on for a second and see if I can answer some of these questions in the Q&A. All right, treating ARFID with an adult. Again, for any of you who are working with adults with ARFID, highly, highly recommend Jenny Thomas and Cameron Eddy's Cognitive Behavioral Therapy for ARFID. It is on Amazon. There is both a manual for clinicians as well as a self-help book for adult patients themselves. So highly recommend both of those things as an approach. Clinical tests to diagnose super tasters. As I mentioned, there are a couple ways of doing this. Some people really do it by like counting the density of taste buds on the tongue. Others, you can use these, they're called prop strips to help with identifying. As I mentioned, though, I'm not a super big fan of super tasting as like a reliable indicator as to whether or not somebody is selective or has ARFID. Or really kind of for drawing any sort of reliable conclusions about their taste and taste preferences. Curious about ARFID and occurring substance use disorder. Great question, Sean. I don't know if you're still on. There is very little data about the co-occurrence of ARFID and substance use disorder. I can tell you that the overlap is very low, and we also do not know very much about it, just in general at all. More resources to address discussed. Krista, nothing specific, but there have been several articles written about it. I've written at least one article talking about it, but the information right now is not, I would say, really well kind of brought together. I'll say just in general, I tend to try to avoid having my patients have disgust experiences as much as possible, because I just find disgust is something very hard to overcome. Like in the anxiety literature, we see disgust as part of a lot of different types of OCD. And we find that disgust doesn't respond to intervention the same way that like anxiety does. So for my ARFID patients, if I'm observing that they're having a really strong disgust reaction to food, and we've tried it a couple times, I will move on, because I don't sort of want to, again, contaminate or poison the whole experience of trying new foods. So I tend not to push foods that are super disgust inducing. I'd rather move on to just trying a whole bunch of different things so that we can have a better chance of hitting on the stuff that will be much more acceptable for them. Marcia, wanting to share my FFQ. I think we could probably do that. I will look into that and just see if there's any like proprietary information stuff I need to be aware of, but hope we might be able to share it. And Marcia, please feel free to like reach out or email me at jessie@equip.health, and we can see about sharing of that. Do RDs do the treatment, or is this done with a therapist in tandem? RDs do treatment for ARFID. I think my best recommendation is to have an RD and a therapist teaming up and working together, but our RDs here at Equip do a lot of dietary expansion work. Highly sensitive persons in ARFID. I don't specifically have information about highly sensitive persons in ARFID, but I will say that I think that's tapping again into the fact that we see some domains just in general related to both, again, sensitivity in terms of sensory processing, but also emotional processing. Both of those things are linked to ARFID. And would you change intervention if someone is a super taster, or, okay, thank you for clarifying, Nicole, or just something to keep in mind? I'm not sure because again, I really just let the patient's experiences guide intervention. If I knew they were a super taster, maybe that might hint at some foods to avoid. But again, because being a super taster isn't always a reliable predictor of food preferences, some super tasters really love flavor and love bitter foods, and some don't. So I think the most reliable way to move forward if you knew someone was a super taster would be would you be open to trying some of these foods just to give us a sense of whether or not you're a person who's going to go for them or not, and then use that experience to kind of guide the rest of your interventions. But in general, I'm kind of drawing again on patient preferences, foods that they want to be able to eat, foods that are going to fill gaps in their diet as the foods that we're going to try to experiment and explore in our tasting sessions. Okay. Any recommendations for support for inpatient level of care for early nutrition? Oh, Caitlin, fantastic. There is an amazing paper that was published in the past year by Sasha Gorel, who works at University of California, San Francisco, on how to adapt inpatient protocols for ARFID patients. And I absolutely think that if you are someone who treats eating disorders at an inpatient level of care, you need to adapt your protocols for ARFID patients. I recommend that you adjust inpatient protocols to account for ARFID preferences. This is very different. Let's see. Let me see, Sasha Gorel. That is the author of the inpatient paper. And I can see, I'm going to stop my screen share really quick and see if I can pull up a link to that paper for all of you. I think it's just a really well done paper. There it is, modification of inpatient. So here is the link to it. Hopefully you or someone you know can help you access it, but that is the patient for modifying inpatient protocols. I think it's a really well done paper and agree with all of Sasha's recommendations. All right. Okay, thank you all so much again. Oh, Jennifer, thank you. That one really I appreciate so much. I have really learned the most probably from my patients themselves that I have treated and worked with. So really grateful to have been on kind of the ground floor of this diagnosis coming out and having the privilege to work with a lot of young kids and families and developing my approaches to treatment over the years. All right. Awesome. Okay, thank you all. Thank you so much for joining. Really appreciated having you today.